Jordan Haskell,
I'm Ebony.
Jacayla.
and our presentation is on total hip arthroplasty, in particular the posterolateral approach.
Alright, so for our objectives today, we're gonna define the total hip arthroplasty to the posterior approach. We're gonna discuss the indications for THA. We're gonna talk about the precautions pre and post surgical procedure, discuss the contraindications pre and post procedure, discuss the methods of procedure, and discuss the rehabilitation process.
What is a THA? It is a procedure for severe joint damage. Both the acetabulum and the femur are replaced. There are two different types, the conventional THA and the resurfacing THA. The conventional one is basically replacing the femoral head and as well as the neck, but with the resurfacing THA, the femoral head is only getting replaced. Indications. Some indications are osteoarthritis, which is degeneration and loss of the articular cartilage, rheumatoid arthritis, which is basically inflammation of the joint, displaced femoral neck fractures, and aseptic necrosis, which is basically progressive ischemia that leads to the death of the osteocytes. And here are a few pictures that represents each indication.
Alright, so now we're gonna talk about a couple precautions. When I was doing my research on precautions, it really varies depending on what the surgeon or physician goes by on a regular, but here are some of the most ones I've seen in each individual notation for it. So one of the pre-op precautions is to prep the resident. So, you know, for hip surgeries, you can't have a too low toilet. So that'll be one of the modifications you can make to your home. You wanna make sure that you have family that's there that can help take care of you, because you're gonna have a lot of stuff that you're not able to do anymore. And lower the bed, just different stuff like that when I say prep residents. We're gonna stop taking all NSAIDs. We're gonna stop taking blood thinners. As you know, when you go on the knife, you don't wanna bleed out on the table. Stop taking most supplements. When I read it, it was different ones that they said for different, depending on the doctor. So any like vitamins and stuff that can cause complication during your surgery. Schedule of dental care. When I used to work at Southern Orthopedics, they had a lot of people coming in before they had a hip replacement or knee replacement, because if your mouth is, I hate to say it just like verbatim, like nasty, it can go, the bacteria can get into your bloodstream and cause an infection down to your procedure site. You want to quit smoking, avoid alcohol, and maintain a healthy weight. For post-op, we want to have some weight-bearing and tolerant assistive devices such as crutches or a walker. One of the big things for after surgery is no crossing your legs or your feet. Some people say you can cross your ankles, but definitely not your legs. But if I was a surgeon, I would, as a PT, I would probably tell them to stay away from even crossing their feet, just to be on the safe side. You want to sleep on your back for the first 6 weeks, and all this is gonna take place for 6 to 8 weeks. No reaching across your body, no hip flexion past 90 degrees, no hip internal rotation past neutral, no hip adduction past neutral, and do not lift your knees higher than your hips. Alright. For contraindications for pre-op, we have some vascular dysfunctions such as DVT, septic arthritis, active infections, severe malnourishment, obesity, systematic diseases, untreated immune deficiency, corticosteroid injections. When I read up on that, you can't have it in a 12-week period. So before you have any type of surgery like THA, make sure you're not having any steroid injections in the last 12 weeks prior to the surgery. Loss of musculature and allergy to metal. For post-op, I had a hard time trying to figure out what contraindications were post-op, so I just kind of gave some complications. So some things you will probably see after this surgery is a lead-link discrepancy. You can see blood clots, infections, and reactions to metals if they didn't know they was allergic to metal prior to having their surgery. And sometimes the joint can come out of place out of the socket.
So for the method of this procedure, to start with, you're going to position the patient in the lateral decubitus position. And so that's shown in this picture here. So essentially you just have the patient laying on their side. The leg on the bottom will kind of be flexed in, and you can have some sort of support in between the legs. For the procedure, a lot of the time you'll see that the leg on the top, which is the leg that's being operated on, will be supported by about 4 different supports. So the procedure is going to begin with an incision placed about 7 centimeters posterior to the hip joint. And this location will just allow the direct access to the femoral head and the acetabulum. And compared to the traditional approach, the incision is relatively small, helping to reduce soft tissue damage and overall just improve the rate of recovery. Then you will go into the muscle separation. So after the incision is made, the glute max muscle will be split to expose the underlying structures. And then from here, the short external rotator muscles will be detached from the greater trochanter. These muscles will include the piriformis and the obturator internus. And throughout this process, there will just be extra care taken to help to protect the sciatic nerve. And so this approach just will help preserve strength and function post-surgery. Then after the soft tissue structures are released, the femoral head will then be dislocated. This is done by just internally rotating the femur, which will help allow the femoral head to pop out of the acetabulum. And this will help provide full access to the hip joint for the next phase of the procedure. Once the femoral head is dislocated, the surgeon's then going to remove the damaged femoral head. The acetabulum will be reshaped to create a smooth surface for the prosthetic implant. And then we'll start doing the preparation of the bone just to ensure a secure fit for the prosthetic device. Then a dual mobility cup, or a DMC, will be inserted into the acetabulum to improve stability and reduce dislocation risk. The femoral component will then be implanted, and this will just help to ensure that there's proper alignment and fit. And the overall use of the dual mobility cup has been shown to reduce post-surgical dislocation rates. Finally, after all of this, the prosthetic components are in place. The surgeon will reattach the muscles, and then the external rotators will be reattached to the hip to restore stability. Soft tissue and skin will then be closed in layers to promote proper healing. And this closure process just will help reduce the risk of infection and ensure smooth recovery. And so this is going to be a video that just shows an animation of what a total hip arthroplasty would look like.
Total hip arthroplasty, also called total hip replacement, begins with an incision to allow access to the bones of the hip joint. The next step is to remove damaged cartilage and bone from the acetabulum, the cup-shaped hollow in the pelvic bone. This damage results from the bones rubbing directly against each other when protective cartilage wears away. A tool called a reamer is used to prepare the acetabulum to receive the socket portion of the hip replacement. This metal and plastic combination is called the acetabular component and is fitted into the newly reamed bone surface. The outer metal part of this component, sometimes called a cup, fits directly into the socket. The inner plastic portion has a hollow to hold the replacement for the ball-shaped bone at the top of the thigh bone, or femur. The outer metal part is rough to help bone grow into its surface over time to lock the artificial socket in place. The next step is removing the ball-shaped head of the femur, or thigh bone, and preparing the femur for placement of the stem portion of the component. A metal ball is attached to the end of the stem and fits into the artificial socket in the hip bone. Together, these components replace the natural ball and socket joint. During and after surgery, the surgeon verifies the correct fit and range of motion of the hip replacement components. By mimicking the anatomy and functioning of the natural hip joint, hip replacement can reduce pain and permit a return to many activities.
So for the rehab process, after surgery in the maximal protection phase, the overall goals are going to be to protect and promote tissue healing, reduce pain and edema. We want to focus on pain-free range of motion and start to begin to initiate muscle activation. The interventions that we'll choose for this would be the Rice method, which is the rest, ice, compression, and elevation. We will want to begin some gentle passive range of motion, as well as glute sets and quad sets. And then for this phase, the overall precautions will be to focus on not flexing the hip past 90 degrees and not allowing any hip internal rotation or adduction past the neutral position. So then for the moderate protection phase, the goals will be to restore full passive range of motion and active range of motion. We want to focus on overall strengthening, work on the posture and pelvic control, and then begin gait training. Our interventions for this will be light active range of motion. We will put the patient on a upright bike. We'll begin mini squats, only to about 70 degrees. We'll do resisted side steps, 3-way straight leg raises, to go to standing, and then ankle weights, and then we'll focus on leg press as well. The precautions for this phase will be that we still don't want any hip flexion past 90 degrees and no hip internal rotation or adduction past neutral as well.
And during the minimum phase, some of those goals include returning to normal function and also to improve strength and endurance and balance as well as proprioception. Some interventions that could be done during this phase are double leg to single leg strengthening. An example of that is like the leg press, core strengthening, and stability ball exercises. Just work on that, like stabilizing and core engagement. And precautions during this phase include avoid hip flexor and adductor inflammation as activity increases, and to ensure that the patient maintains pain-free range of motion as strengthening continues and increases.
So for the overview, this surgical procedure that we've talked about involves replacing the femoral head and the acetabulum. Common indications for this would include osteoarthritis, fractures, and avascular necrosis. Certain key precautions that we want to focus on is to avoid hip flexion past 90 degrees, overall any adduction and internal rotation. This posterior lateral approach that we talked about involves muscle splitting and prosthetic placement. The rehab process will focus on pain control, mobility and strength, and getting the patient back to functional recovery. And then the long-term goals will be to teach the patient to avoid any high impact activities and to ensure that we're working on maintaining strength and mobility. And these are our references. Are there any questions?
For the metal allergy, as a PT, looking after that, what would that look like for him?
Since after surgery we do have to pay attention to the skin and integrity and all that stuff. You would look like for any kind of allergy reaction, redness, itchiness, any bruising kind of to that area depending on the skin tone of the patient. And whenever we see that, we make sure we have to tell the physician or surgeon ASAP because that can lead to an infection if not treated.
Kira?
How long is the typical rehab process?
So when I was doing my research, I saw that typically it'll be up to 8 weeks, but that the patient can begin to go back to light activities on their own around 6 weeks.
In my reading, I noticed that this approach is most susceptible to hip dislocations. Why do you think that is?
Because of the muscle splitting, so the muscles are not strong enough to kind of like keep things in line. You know how you centrifuge contract and contract, they stop to give you stability. Since it's split, it probably won't allow you to be stable. The weakness of the muscle.
So,
What's the timeline difference between the conventional and the resurfacing and replacement conditions?
Well, the conventional THA, the femoral head and the neck are both being replaced, but with the resurfacing THA, only the femoral head is being replaced, so therefore the femoral neck is like more susceptible to like getting fractured during like the rehab stage. So you want to be careful when working with your patients that had a resurfacing THA.
Any other questions?
Alright, thank you so much.
Alright, comment. Just comment, so you talked about dislocation, it's a big deal with the posterolateral approach. How many of you have seen patient in the clinic? Have you seen patient in the clinic with the TJ? So I think you're probably starting to see this approach less often than the anterior, starting to become a lot more popular. But you'll still see this, and especially with some of your older patients and things like that. But why do you think they have those hip precautions? Why do you think they have those precautions with this approach? Okay, it is. Why do you think it's easier for them to dislocate those positions? See if you can extrapolate from what you learned.
Because if you're doing the posterior lateral approach, like you're going in posteriorly, so what I can think of is during flexion, we know that the head is gliding posteriorly, so it'll be like more easier to dislocate since the head is gliding posteriorly during that hip flexion.
Yeah, I wasn't even thinking that, but that is absolutely right. So you're right. The arthrokinematics, we know that puts stress there, but that's also how they dislocate it to get it out in the first place to do the procedure, right? You said internal rotation, but I think they also take it into full flexion, adduct, internally low rotate, and pop it out. So for that reason, those positions are where you're going to be more vulnerable and susceptible to dislocating, and of course the muscle splitting, like you said, it's just not as stable right out of the gate. And probably the farther down the road that you go from the hip replacement without having a dislocation, probably the safer you can be going into that. But early on, you definitely do want to be cautious. And anybody and even if you see somebody 3-6 months down the road, if they've had a dislocation